He's a 12-year-old boy that has been in previously good health. In 2007, he started having some symptoms of difficulty initiating sleep with some complaints of weight gain. So, as any good pediatrician would do, they placed him on a weight management program, and he did, in fact, successfully lose about 15 to 20 pounds. About 2008, he presented again with his sleep issues that continued to worsen. He started beginning noticing striae on his abdomen, redness and lesions under his eyelids, with easy bruising, decreased stamina, easy fatigability, worsening headaches, and started having issues with facial acne, axillary, and pubic hair. So in December of 2009, he was referred by his pediatrician to a local endocrinologist where the main chief complaint was a short stature evaluation. Apparently, he had been having a progressive decline of his height percentile from the 90th to 25th percentile. And on the physical exam notes, it was found that his blood pressure was 132/97, elevated for his age, and had clinical signs that were concerning for Cushing's syndrome. So these were the preliminary labs that the outside endocrinologist had performed. As you can see, the AM cortisol was slightly elevated at 25.8. ACTH levels were in normative range, but the urinary free cortisol was elevated at 202, normative range being 1 to 21 micrograms over a 24-hour period. And the other regional workup, the androstenedione, was elevated at 326. Further evaluation by the outside yielded some radiographic studies with a bone age that was performed when he was 11 years and 2 months that was read as a bone age of 12 years and 6 months to 13 years. He also had an abdominal x-ray that was read as normal, an ultrasound of his abdomen that showed a 0.9 centimeter left renal cortical cyst, and a brain MRI that was done at Riverside Medical that was read as completely normal. So he also underwent in January 2010 a dexamethasone suppression. Now we assume that it's a high-dose dexamethasone suppression with a subsequent CRH stimulation test. We don't have any baseline ACTH or cortisol levels prior to his high-dose dexamethasone, but in the morning you can see that this ACTH and cortisol was still slightly elevated at 64.8 and 21.4. with subsequent increase of cortisol up to a peak of 52.2. He subsequently came to us here at UCLA first on August of 2010, and he was already on medications for his blood pressure, including lisinopril and spironolactone. He was still having symptoms of diarrhea, headaches, flushing, blurry vision, and fatigue, still not really doing clinically that well. Otherwise, his past medical history was negative, and a family history was only significant for hypertension on the mother's side, type 2 diabetes on both sides of the family, and rheumatoid arthritis on the mother's side. Physical exam. His physical exam showed a height that was in the 10th percentile, with his weight being 90th to 97th percentile. This equated to a BMI of 30.2, which was greater than the 97th percentile. Pulse rate was around normal at 109, but his blood pressure still remained elevated of 136/96. His exam findings were significant for moon facies. He had pustules along the inferior palpebrae sulci bilaterally, and significantly he did not have any exophthalmos or any disc abnormalities on fundoscopic exam. His neck exam was significant for a buffalo hump posteriorly, but no thyromegaly, and cardiovascular exam was otherwise normal. Did have mild central striae on abdomen with a genitalia pubic exam of 10/3 for pubic hair and 10/2 for genitalia, 4 cc's bilaterally. His skin exams were significant for long, dark pink striae on his axillary region as well as along his bilateral lower extremities. He had mild cystic acne diffusely on his face with large ecchymoses on his right upper extremity. He also had a hemangioma that he's had for pretty much his whole life, along with satellite lesions on his right upper extremity. He was known to be diffusely hirsute with small punctate papules along his anterior chest without any signs of any acanthosis. So we have some pictures of this child, and you could see here, tend to catch basically moon facies. Here we are trying to create a picture of his buffalo hump, which wasn't that successful. This is his right thigh, right lower extremity, and this was intended to show his pink striae. And on his arm, he's been noticing a lot of bruisability as well, and this is just something that was on his right arm. So we did some repeat testing as well as some laboratory examinations and found that his cortisol and ACTH were indeed elevated, with a urinary free cortisol that was again elevated at 257 micrograms over a 24-hour period, and his thyroid and his growth factors were completely normal. So the next step we undertook was to get inferior petrosal sinus sampling that was done on October 20th. And here we have the results of ACTH levels from his right inferior petrosal sinus compared to his left, and in comparison to his inferior vena cava. And as you can see, already pre-CRH injection, he had a 5-to-1 gradient from central to peripheral, as well. Then increased about a 10-to-1 gradient when CRH was injected, and he has about a 2-to-1 gradient when you compare right to left. And reports are that a positive finding for IPSS is that if you have a 2-to-1 gradient central to peripheral, it's more indicative of a central cause of Cushing's disease. And if you have a greater than 1.5-to-1 roughly ratio from right to left, it'll be a lateralization findings for that. So also in the meanwhile, we had gotten a high contrast chest, abdomen, pelvic CT that was read as the outside as normal. While we are waiting for a subsequent brain MRI, which the first repeat done here was done in August 2010 as a dynamic study which showed a linear focus of hypointense T2 signal between anterior and posterior pituitary suggestive of Rathke's cleft cyst with no hypoenhancing mass suggestive of microadenoma. And he's had repeat pituitary MRI studies in November 2010.